Let us now discuss the motor system. It's about voluntary movements, how we decide and perform the voluntary movements, what all things are involved, what all parts of the CNS are involved in the performing of voluntary movements, and various motor neuron diseases, what are the manifestations. At the outset, just to give you a feel of what is coming up, there is one question, one MCQ. When a man is deciding on a voluntary movement, first impulse will be recorded from which part of the brain? And the options are premotor cortex, primary motor cortex, cerebellum, or basal ganglia. Well, the option is premotor cortex. When a man is deciding on a voluntary movement, the thought, the idea comes in the premotor cortex. So such questions can be asked. As we will move further, we will see some more MCQs related to the motor system. What all things we will cover is organization of the motor system and various descending tracts, cerebellum, basal ganglia, and then lower motor neuron. Let's start with the first part, the organization of the motor system. It starts with the cortex. Let's see some aspects of the motor cortex. There is a central sulcus. Then in front of the central sulcus, in the frontal lobe, there is motor cortex. So decision for the voluntary movement is going to be taken in the motor cortex in the frontal lobe. Now, immediately in front of the central sulcus, that's precentral gyrus, area 4 is called as primary motor cortex, and then area 6 is called as premotor and supplementary motor areas. That's area 6. These are the two main areas which are concerned with the voluntary movement. So we are mainly concerned with these areas. Apart from that, there are some more areas in the frontal lobe, like area 8 is called as frontal eye fields. Frontal eye fields, voluntarily tracking an object which is in the field of vision, is the function of these frontal eye fields. Apart from this, since we are talking of the frontal lobe, let me just add one more point which is not actually a motor cortex area. Areas 9, 10, 11, 12 in the prefrontal cortex, they are said to be seat of intelligence and social behavior. So seat of intelligence in the prefrontal cortex, most anteriorly, 9, 10, 11, 12. Of course, they are not concerned with the current discussion. We are currently talking about the motor cortex. In the motor cortex, the body representation is contralateral and roughly inverted. If you see the coronal section of the brain, and the motor cortex has the map of body parts called as motor homunculus. Just as there was sensory homunculus, there is a motor homunculus, the map of body's muscles. So there is a face, there is thumb and other digits, and then other body parts. Well, Greatest representation in the motor homunculus is to the thumb and muscles of vocalization and mastication, chewing and speech. These two areas get largest representation in the motor cortex because these two are going to perform the most skilled of the motor activities. Let me just mention one point. If you see the face in the sensory homunculus and if you see the face in the motor homunculus, they were originally, these mappings were done by Penfield and Rasmussen, and they were named as sensory homunculus, motor homunculus, the maps of body areas. If you see those maps, in the sensory homunculus, the mouth is shown to be closed and lips are swollen. Lips are shown to be swollen, meaning lips are occupying a large area. They want to show that lips are occupying a large area in the sensory cortex. So lips are more sensitive, lips and face. And if you see in the motor cortex, they show lips are normal size and mouth is open. So what is the meaning of that in the motor cortex? It means muscles of speech, muscles of vocalization and mastication. Therefore, mouth is shown open. Whereas in the sensory homunculus, mouth is closed but lips are shown to be swollen. So they are occupying large area in the sensory cortex for sensation. That means that's the motor cortex and its areas. Let us see the organization of the motor system and functions of various parts. When a man decides on a voluntary movement, first impulse is recorded from his premotor and supplementary motor areas, area 6. Here, the thought for the voluntary movement starts. The thought, the idea of a voluntary movement. Suppose you are seated in the lecture hall and the cell phone rings and it's at a certain distance. There will be first just a thought that I need to do something about this. The cell phone is ringing. This thought, therefore, for any voluntary movement, first impulse will be recorded from the premotor and supplementary motor areas, area 6. This thought will be then transferred to the basal ganglia. So it means the second impulse will come from the basal ganglia for a voluntary movement. Then what will be the contributions of basal ganglia in the voluntary movements is this. Basal ganglia will convert the abstract thought into voluntary movement. Convert the abstract thought into a voluntary movement. So there was just this thought that the phone is ringing and I have to do something about it. That was just an abstract thought. It will be converted into a proper voluntary movement that I have to walk, reach to the phone and do what's most appropriate at that particular moment. Basal ganglia will then select the desired movement. There will be 10 movements possible. Basal ganglia will select the most appropriate, most desired movement. Suppress the movement. There may be 10 other movements possible. So suppression of the movement is also a function of the basal ganglia. Then basal ganglia provide spontaneity to the movement, purpose to the movement. They have a certain amount of past memory in the basal ganglia circuit. So they provide a certain spontaneity to the movement, the purpose to the movement. The basal ganglia provide proportion to the movements. our movements have a certain sense of proportion, and that's provided by the basal ganglia. The lesions of basal ganglia, for example Parkinsonism, you see the manifestation, loss of proportion results in micrographia. Micrographia means small letters. The person has lost the sense of proportion. I mean, if you are writing on a page and it is being read by one person, how much should be the size of the letter? And if you are writing on a board and 100 students are going to read it, what should be the size of the letters? Is a sense of proportion, and that's lost, and therefore there is micrographia, small letters, in Parkinsonism, lesion of the basal ganglia. Well, so basal ganglia will provide all this to the thought process, I mean to the voluntary movement. So that was the second part in the motor system. Then third impulse will come from the cerebellum. Cerebellum, see, now it has been almost decided what movement is to be done. Then cerebellum will give sequencing of muscle contractions. Once the movement has been decided that the appropriate movement is that lecture is going on and cell phone is ringing, it's a disturbance, so most correct thing is to walk up to the phone and switch it off. Once that has been selected, then cerebellum will provide sequencing of muscle contractions, that you have to first contract the lower limbs to reach to the phone, then contract the upper limb to pick up the phone, then switch it off. That's sequencing, that's provided by the cerebellum. So these are to and fro connections, cerebellum with the motor cortex, basal ganglia with the motor cortex. And then fourth impulse will come from the primary motor cortex, area 4. Now this, according to the sequence provided by the cerebellum, a command will be formed for the concerned muscles. A command will be formed for the concerned muscles by in the primary motor cortex. The command will be formed for the concerned muscles, and that command will be sent down for execution onto the spinal cord. So command now will be sent down for execution according to the sequence provided by the cerebellum. This sending down of the command will occur via two groups of descending fibers. As you can see, one set of fibers starting from the cortex directly end on the spinal cord. This is called as corticospinal tract. Fibers of this tract, while they are passing through the medulla, they create pyramids in the medulla, for which reason this has been described as the pyramidal tract. So what all functions performed by the corticospinal tract or pyramidal tract? It initiates the voluntary movement. It initiates the voluntary movement. As per the command, now the execution starts. It controls the distal muscle groups. It controls the distal muscle groups of hands and feet. So it controls stance and gait. It controls thumb. It controls thumb and therefore controls skilled voluntary movements. So that's the function of the corticospinal tract. Well, how it has happened? Planning and programming occurred in the cortex. Basal ganglia helped in the planning and programming. So did the cerebellum. And then execution part now is corticospinal tract. It performs these functions. It will start the movement, initiate the movement. It will control the distal groups of hands and feet, thumb, the skillful movements. All the other descending tracts that started from the cortex they end in the brainstem nuclei. Brainstem nuclei. And a fresh set of fibers arise from those brainstem nuclei and end on the spinal cord. These are described as extrapyramidal tracts. Extrapyramidal tracts. So, corticospinal tract, the fibers from cortex to spinal cord. When we say pyramidal tract, let's just have a clarity on this. When you say pyramidal tract, all the fibers, they will form the pyramidal tract. So, corticospinal, corticobulbar and corticonuclear. Corticospinal is clear to us, cortex to spinal cord. There are also corticobulbar and corticonuclear fibers from cortex to the brainstem nuclei. So, it's something like this, that a face controlling area in the motor cortex will send signals to the brainstem nuclei. There will be a facial nerve nucleus. So, those face controlling fibers will come to the facial nerve nucleus over here, and then infranuclear fibers of the facial nerve will go and innervate the facial muscles. So, that would be an upper motor neuron and a lower motor neuron. Infranuclear fibers will be the lower motor neuron. Or the other fibers, so this is the pyramidal tract which has corticobulbar, corticonuclear and corticospinal tracts. All the other tracts outside the pyramids, see these fibers were creating pyramids in the medulla as they were passing through the medulla. So it was called as pyramidal tract. All the fibers outside the medullary pyramids are described as extrapyramidal tracts. So you can see brainstem nuclei to spinal cord. These will be the extrapyramidal tracts. They are outside the pyramids. Pyramids were formed by these corticospinal fibers. What are the names of those extrapyramidal tracts? 4 extrapyramidal tracts. 1. Vestibulospinal tract. From vestibular nuclei of the brain stem to the spinal cord. Vestibulospinal tract. It does what? It controls posture and equilibrium. Controls posture and equilibrium. So, suppose you rotate the head. We have already discussed this in the vestibular apparatus. You rotate the head, vestibular apparatus is stimulated, vestibular nerve arises, comes to the vestibular nuclei over here, and then the vestibulospinal tract, it will control the anti-gravity muscles and control the posture and equilibrium, so that head is rotated but body will have a balance. Second, reticulospinal tract. Reticulospinal tract, from reticular nuclei to the brains to the spinal cord. Reticulospinal tract, it controls the trunk muscles. Trunk muscles, axial muscles of the body. So basically vestibulospinal and reticulospinal together will control the posture and equilibrium, balance of the body, axial muscles of the body. Then third one is rubrospinal tract. From the red nucleus of the mesencephalon to the spinal cord, rubrospinal tract. It will control what? Rubrospinal tract controls more proximal muscles. Proximal muscle groups. So we have the account of all the muscle groups. Distal muscle groups by the corticospinal tract, proximal muscle groups by the rubrospinal tract, and the trunk muscles and axial muscles by the vestibulospinal and reticulospinal tract. One more, tectospinal tract. Tectospinal tract. Roof of the midbrain is called as tectum, floor is called as tegmentum. In the roof of the midbrain, there are 4 bodies like this. So it's called as corpora quadrigemina, 4 bodies, so quadrigemina. two superior colliculi, two inferior colliculi. Superior colliculi are connected to the visual pathway. Inferior colliculi are a part of hearing pathway. So when you say tectospinal tract, it controls what? It controls movements in response to visual and auditory inputs. Movements in response to visual and auditory inputs are controlled by tectospinal tract. So these are the four extrapyramidal tracts. Let me just quickly add, what is extrapyramidal system? Very often you discuss about pyramidal lesions and extrapyramidal lesions. Basal ganglia lesions are described as extrapyramidal lesions. So what is the extrapyramidal system? Extrapyramidal lesion means what? Why basal ganglia lesion is called as extrapyramidal lesion? These extrapyramidal tracts, the cortical areas that control them, and basal ganglia connected with those cortical areas, this forms the extrapyramidal system. The extrapyramidal tracts, the cortical areas that control those tracts, and the cortical areas connected with the basal ganglia. This entire system is extrapyramidal system. So that's these are the tracts. Let us see one more terminology before we move on. Pyramidal and extrapyramidal has always been very confusing. So a rather different terminology sometimes used. Look, corticospinal tract, when it enters the spinal cord, majority of the fibers, they run on lateral aspect of the spinal cord, called as lateral corticospinal tract. So lateral corticospinal tract and rubrospinal tract, they run together on the lateral aspect of the spinal cord, and they constitute what is called as lateral motor system of the cord. Corticospinal tract and rubrospinal tract constitute lateral motor system of the cord. The remaining three tracts, vestibulospinal, reticulospinal, tectospinal, these three, they run on the medial aspect of the spinal cord. So it's called as medial motor system of the cord. This one MCQ has been asked in recent exam. Which of the following is not a part of medial motor system of the cord? Vestibulospinal, reticulospinal, rubrospinal and tectospinal. The answer obviously now is rubrospinal, which forms the lateral motor system of the cord. So this terminology is also often used nowadays. Let us discuss about corticospinal tract before we move on to the next parts of the motor system and voluntary movement. Corticospinal tract, its origin in the cortex is like this. 30% fibers, they start from area 4, 30% fibers, they start from area 6, and 40% fibers, they start directly from the parietal lobe. Sensory cortex, 40% fibers, so 30, 30, 40. So note this point, that sensory cortex is where sensations from the periphery, their signals come and end there, and 40% of the motor fibers are starting from the sensory cortex. These fibers are involved in sensory motor integration, sensory motor association. After all, many of our movements are in response to some kind of a sensory input. This is just giving an example. I mean, we feel cold and then we go on to switch off the AC. So this movement was made in response to the sensory input of cold. So there is a sensory motor integration, and these 40% fibers are mainly for that purpose. Out of all these fibers of the corticospinal tract, 3% fibers they arise from a very large cell called as pyramidal cell. Large cell called as pyramidal cell. It's a giant cell, giant bed cell or pyramidal cell. This is a very large nerve cell body, and it's a heavily myelinated. These nerve fibers are heavily myelinated, and most rapidly conducting descending tract is this giant the fibers that arise from the giant bed cell, and these are the facilitatory fibers or excitatory fibers. These fibers, they will initiate the voluntary movement, and since they are going to initiate the voluntary movement, they are facilitatory, excitatory, and they are most rapidly conducting descending tract fibers at 120 meters per second. The remaining 97% fibers are the fibers from the normal neurons, and they exert inhibitory influence. You must understand at this point of time that upper motor neuron and lower motor neuron, motor system functioning is governed by two neurons, a two neuron path, upper motor neuron and lower motor neuron. Let's simplify this. From the motor cortex to spinal cord would be the upper motor neuron, and from there to the muscle will be the lower motor neuron, the anterior motor neuron or the lower motor neuron. So upper and lower motor neuron. Now this upper motor neuron predominantly exerts an inhibitory influence. Just about a few percentage of fibers will be excitatory. They are to initiate the voluntary movement. But otherwise, upper motor neuron predominantly exerts an inhibitory influence on the lower motor neuron. So remember this, that if there is a lesion of the upper motor neuron, then that inhibitory influence will be lost, and therefore then lower motor neuron will fire excessively. That inhibitory check is gone. Therefore, in the upper motor neuron lesions, pyramidal tract lesions, you see hypertonia. Muscle tone has increased. There is spasticity and exaggerated tendon reflexes, excessive signaling to the muscles. Whereas in the case of lower motor neuron is a final common path going to the muscle. If that itself is lesioned, then no signals are reaching the muscle. Therefore, muscle tone will be lost. There will be hypotonia, and tendon reflexes also will be absent. So that's a upper motor neuron versus lower motor neuron. This is the population of the pyramidal tract fibers or corticospinal tract fibers. Pyramidal includes, of course, as I said, corticospinal, corticobulbar and corticonuclear. And just one last point about this corticospinal tract fibers. They arise from all these areas that I mentioned just now. The 30% from the area 4, 30% from area 6, 40% fibers from the sensory cortex, and then they converge and make a bundle. They converge and make a bundle to start running down. So this appearance is called as corona radiata. Corona is crown and the radially appearing fibers. This then, as they come down, they go through the posterior limb. Anterior 2/3 of the posterior limb of the internal capsule. To be precise, this is the posterior limb of the internal capsule. This is the anterior limb. So the fibers are going down through the posterior limb, but anterior 2/3 of the posterior limb. So these fibers, they come down through the internal capsule, then they have come through the midbrain, pons, the compact bundle, loosens up somewhat. This compact bundle will loosen up because corticobulbar and corticonuclear fiber will go on ending over here in the midbrain pons, and finally corticospinal fibers are continuing. So 85 to 90% fibers will cross the midline and go to the opposite side in the lower medulla. This will happen in the lower medulla. So we saw in the sensory system, in the upper medulla, the medial lemniscal fibers were crossing to the opposite side. That was causing sensory decussation, crossing over of fibers. Here it is a motor decussation in the lower medulla. 85 to 90% fibers cross the midline and enter the spinal cord, and they start running on the lateral aspect of the spinal cord. So this is called as lateral corticospinal tract. Lateral corticospinal tract. Remaining 10 to 15% fibers had remained on the same side when they entered the spinal cord. They will run on the anterior aspect of the spinal cord. That's called as anterior anterior corticospinal tract. But eventually, all these fibers which remained uncrossed, see, we have crossed pyramidal tract and uncrossed pyramidal tract. Eventually, these 10-15% fibers also will cross the midline by upper thoracic to mid thoracic segment level. They will also cross the midline. So all fibers are going to cross the midline and reach the opposite side. That's the corticospinal tract, its origin, course, termination. Most of these fibers will terminate first on the interneurons in the spinal cord, which will then signal the anterior motor neuron or the lower motor neuron coming out and going to the muscles. So that's the organization of the motor system. Well, but the story is not yet over, because movement has been initiated by the corticospinal tract. Now the major role of cerebellum will come into action. The muscles begin to contract, and as the muscles begin to contract, there is change of length, moment to moment change of length, and this moment to moment change of length conveyed from the muscle to the spinal cord, and from the spinal cord it is sent into the cerebellum. This will be called as unconscious proprioception. Mind you, this is not reaching consciousness because this is a voluntary movement. Muscles are contracting rapidly. Their movement, their length is changing very rapidly. So it will reach the cerebellum. It will be sent to the cerebellum. It is unconscious proprioception carried by spinocerebellar tract. Spinocerebellar tract carries unconscious proprioception. And then, according to this signal, cerebellum will compare the two. What is the intention of the cortex and what's happening at the muscle level. After the this is called as a comparator function. And after the comparison, then cerebellum will send the signals back and adjust the muscle contractions. So now, initiation of the movement was the function of corticospinal tract, but once the movement starts, then it's the job of cerebellum. Cerebellum is the master coordinator for the voluntary movements. So that's the function of cerebellum. Please note a few distinguishing points between cerebellum and basal ganglia. For one, the point is that basal ganglia is only exclusively connected with the cortex. Cerebellum is connected with the cortex, and cerebellum is also connected with the spinal cord, and from there to the muscles, of course. So it's the master coordinator for the voluntary movement. This is the organization of the motor system and parts and the functions of various parts. Let us now understand the cerebellum. since we are talking of the voluntary movement, let me just say one more point, and that is, before we start discussing the cerebellum, walking is a voluntary movement. Walking has a certain pattern. Where is the pattern generator for walking? Whether it's cerebellum, basal ganglia, spinal cord or motor cortex. The answer is spinal cord. Pattern generator for walking is in the spinal cord. Let us now discuss the cerebellum, the master coordinator for the voluntary movements. There was an MCQ on cerebellum. Eye rotation in response to head movement is controlled from which part of the cerebellum? The options are flocculonodular lobe, paravermis, paliocerebellum, neocerebellum. The answer is flocculonodular lobe, which is vestibulocerebellum. Let's try to understand this. There are three functional divisions of the cerebellum. The flocculonodular lobe and a central thin portion of vermis. It makes the first functional division of cerebellum called as vestibulocerebellum, because this part is connected with the vestibular apparatus and the vestibular nuclei. This is also oldest in evolution. So it is also called as archicerebellum. What is the function of archicerebellum? Two functions. One is control the posture and equilibrium, and control the eye rotation in response to head movement, or better called as vestibulo-ocular reflex. Vestibulo-ocular reflex, as we have described it in the vestibular apparatus. So, flocculonodular lobe or vestibulocerebellum or archicerebellum, they are all the names of that same part. Then next, second functional division of the cerebellum. On either side of the vermis, there is paravermis, parallel to the vermis. That forms the second functional division called as spinocerebellum. This part is connected to and fro with the spinal cord. This is old in evolution, but not as old as archie. So it is called as paliocerebellum. What are the functions of paliocerebellum? It is connected with the spinal cord and thereby to the muscle via spinal cord. So its functions would be, it coordinates between muscle groups. Coordination between muscle groups, so that the movement is smooth. Smoothening of the movement. It makes the movement precise and well coordinated. Damping function of the cerebellum. Damping function. Well, when we are approaching the target and the muscle contraction is too intense, then we are likely to go past the target, beyond the target. So the movement has to be damped and the contractions have to be suddenly stopped. That's the function of cerebellum, damping function. In fact, lesion of the cerebellum will result in past pointing. The person goes past the target because there is no damping due to the lesion of cerebellum. Alternate rapid movements. Alternate rapid movements like pronation, supination, and in the lesion of cerebellum, there is failure to perform alternate rapid movements, which is called as adiadochokinesis, adiadochokinesia, or dysdiadochokinesia, failure to perform alternate rapid movements. Also maintain the muscle tone. So these are some of the important functions of spinocerebellum. Third functional division is in the lateral cerebellar hemispheres, and it's called as cerebrocerebellum. Cerebrocerebellum, because this is connected with the cerebral motor cortex. Since it is newer in evolution, it is also called as neocerebellum. Well, one function of the cerebellum is alpha-gamma coactivation. We will discuss this later when we discuss the lower motor neuron. But alpha and gamma motor neurons are simultaneously activated during a voluntary movement, and that's the job of cerebellum. This linkage happens in the neocerebellum, that alpha and gamma motor neurons are simultaneously activated, so that alpha motor neuron causes the muscle to contract, gamma motor neuron maintains the muscle spindle excitability. Muscle spindle is a proprioceptor in the muscle. We will discuss that later. So this is cerebrocerebellum, also called as neocerebellum. Its function is it helps the cortex in planning and programming. Helps. It does not do the planning and programming by itself. Helps the cortex in planning and programming. It provides sequencing of muscle contractions to the cortex. So these are the functional divisions of cerebellum and their roles in the voluntary movement. Let us just quickly see the connections of cerebellum. Connections, functions and effects of lesions. So connections will have afferents and efferents into the cerebellum. Let us see the afferent connections. Afferents coming into the cerebellum. Afferent, and what is its function? What does it carry into the cerebellum? First, we already know there are three functional divisions: vestibulocerebellum, spinocerebellum, cerebrocerebellum. So let's go by that. Vestibulocerebellar tract. What does it carry into the cerebellum? Head orientation and head movement, head rotation, linear movement, angular rotation. You see, it's like this. This is a vestibular apparatus and it conveys the signal into the cerebellum, the vestibulocerebellar tract. The vestibulocerebellar tract. And then cerebellum will send the signal back to the vestibular nuclei, and from there, so this is the vestibular nucleus. It sends the signal down the vestibulospinal tract. Vestibulospinal tract will control the posture and equilibrium. So as soon as we rotate the head, semicircular canals will be stimulated and they will send signals into the cerebellum. That's vestibulocerebellar tract. And then cerebellum will control the vestibular nucleus, which is actually controlling the posture and equilibrium. Vestibulospinal tract. Dorsal spinocerebellar tract. Dorsal spinocerebellar tract. We already discussed this, that spinocerebellar tract, it conveys the unconscious proprioception. During the voluntary movement, there is very rapid change in the muscle length and it is sent into the cerebellum. That's unconscious proprioception particularly from lower parts of the body. Particularly from lower parts of the body. Then there is ventral spinocerebellar. Ventral spinocerebellar carries what into the cerebellum? It carries the so-called efference copy of the anterior motor neuron. Efference copy of the anterior motor neuron. Let's try to understand this. By the way, ventral spinocerebellar tract is the fastest ascending tract in the spinal cord, 120 meters per second. Fastest descending tract was corticospinal tract fibers arising from the giant bed cell. This is the fastest ascending tract in the spinal cord, ventral spinocerebellar tract, and it carries the efference copy of the anterior motor neuron. Now, what is that? You see, motor cortex conveys its intention of the voluntary movement into the cerebellum. Intention of the movement is conveyed into the cerebellum. And when cortex initiates the voluntary movement, muscles start contracting. Then moment to moment change of length of the muscle, the unconscious proprioception. It comes from the muscle to the spinal cord, and from the spinal cord it goes into the cerebellum. Fine. Apart from these two signals, I mean one from the cortex regarding the intention and one from the muscle as to what is actually happening at the muscle. Apart from these two, there is one more signal which we are discussing now, the ventral spinocerebellar tract, is efference copy of the anterior motor neuron. Look, there is anterior motor neuron. It is going to send signal to the muscle for the contraction ahead and ahead and ahead. Those signals will be sent from anterior motor neuron to the muscle. Now, this anterior motor neuron receives signals from multiple sources. I mean, a signal from the cortex, signal from the cerebellum, there is a reflex arc, and then based on all this, then anterior motor neuron will finally send signal to the muscle for contraction. What is it going to tell the muscle to perform? That, a copy of that, before it is sent to the muscle, it is sent back into the cerebellum. That's called as efference copy of the anterior motor neuron. So, cerebellum knows intention of the cortex, what movement has to be performed. Cerebellum knows what muscle is doing from moment to moment, because that signal is also going into cerebellum. And cerebellum knows what the anterior motor neuron is going to tell the muscle to perform, to contract. A copy of that goes back into the cerebellum. That's efference copy of the anterior motor neuron, so that cerebellum can take the decisions accordingly and perform the movements very, very smoothly and precisely. So, we are talking about the afferents into the cerebellum, ventral spinocerebellar. Next is the next fiber coming into the cerebellum would be cuneo-cerebellar tract. Cuneo-cerebellar tract. Remember the cuneatus, fasciculus cuneatus, fine touch from the upper limb was carried by the fasciculus cuneatus. So cuneo is related to the upper limb, and therefore cuneo-cerebellar tract carries proprioceptive impulses from the arm and neck, upper limb and neck portion are carried by the cuneo-cerebellar tract. Next afferent into the cerebellum is tectocerebellar tract. Tectocerebellar tract, from the tectum into the cerebellum, from the superior colliculus into the cerebellum. So, just an additional info. Visual pathway sends one set of signal to the superior colliculus, and therefore one more structure related to the visual pathway is the superior colliculus. Now this superior colliculus sends the signals into the cerebellum. This is tectocerebellar tract. We know the tectum has two superior and two inferior colliculi. So this connection is conveying the visual impulses into the cerebellum, and then accordingly there is a tectospinal tract, and cerebellum will also send signals directly on the spinal cord. So this would be the circuit for eye-hand coordination. Eye-hand coordination, the central role is played by superior colliculus, because it is receiving impulses from the eye, conveying it into the cerebellum, and also tectospinal tract is controlling the hand muscles, cerebellum also coordinating the hand muscles directly. So that's a circuit for eye-hand coordination. Superior colliculus is a structure that controls regulates the eye-hand coordination. Next is cortico-pontocerebellar tract. This is the longest tract in the brain. Longest tract in the brain is pontocerebellar tract, because cortico means motor cortex. Motor cortex in the frontal lobe, and from there cerebellum is a part of the hindbrain. So from the motor cortex in the frontal lobe to the hindbrain, this is the longest tract in the brain, from motor cortex to the pons and into the cerebellum. What does it convey? It conveys the intention of the cortex regarding the voluntary movement. And the last but the most important tract is, in fact, one should understand that all these tracts on one hand and this tract alone is different. I'm talking about olivocerebellar tract. Olivocerebellar tract. Now, let's try to understand what is olivocerebellar tract. There is an area in the medulla inferior olive. From there to the cerebellum, olivocerebellar tract. What does it carry? You see, all these areas and tracts that I have mentioned so far, they send the fibers directly into the cerebellum. The single fibers from those sources will come and go into the cerebellum, or one more set of fibers arising from these sources, multiple sources. They will come and first converge on olive, and a single bundle will go into the cerebellum as olivocerebellar tract. So, converged input from multiple sources. Try to understand that cerebellum is receiving double inputs. One is that individual sources are sending fibers directly to cerebellum. Those are individual fibers from that particular source, or multiple of those sources, they send one more set of fibers, which all these fibers will first converge on olive, and then a single bundle will enter as olivocerebellar tract. So it's a converged input from multiple sources, and remember, therefore cerebellum is receiving double inputs from each source. So these are the afferents into the cerebellum. Let us see the efferents from the cerebellum. Before we understand the efferents from the cerebellum, let's just see the histological structure of the cerebellum. There is superficial layer or surface layer of the cerebellum. Then there is a Purkinje cell layer, granule cell layer, and then deepest into the mass of cerebellum is deep nuclear cell layer. These are the four layers in the cerebellum: surface layer, Purkinje cell layer, granule cell layer, and deep nuclear cell, deepest into mass of cerebellum. Now, output from the cerebellum, the efferent from the cerebellum, it goes out via deep nuclei of the cerebellum. So, remember this, that output is being given by deep nuclei and it will go to various parts. Second point is there are three functional divisions. So there are three deep nuclei. I mean, names have been given into each functional division for those deep nuclei. For example, vestibulocerebellum. We have three functional divisions: vestibulocerebellum, spinocerebellum, and cerebrocerebellum. The deep nucleus of vestibulocerebellum is nucleus fastigius. Fibers come out and they go to the same structures. So this is a to and fro connection. So fibers go out to the same structures from where they received the impulse. The fibers will go out to the vestibular nuclei and reticular nuclei, and from there the further fibers are sent down on the spinal cord. These are vestibulospinal tracts and reticulospinal tracts. They will control the trunk axial muscles and they will control the posture and equilibrium. The spinocerebellum, as you can see, it is interposed between the two, so it's called as nucleus interpositus. This has got two parts. Anatomy will tell you that it has got two parts, this nucleus. The globose nucleus and emboliform nucleus. Nucleus globosus and nucleus emboliformis. So, the fibers come out from the spinocerebellum. They will mainly go to the red nucleus, and then there is rubrospinal tract. It will control the proximal muscle groups. And cerebrocerebellum, its deep nucleus is called as dentate nucleus. Fibers will come out and via thalamus, which we have already seen. There are three nuclei of the thalamus that are connected with the cerebellum and basal ganglia. They are involved in the motor function. Those thalamic nuclei are ventro-anterior, ventrolateral and centromedian nuclei. Via these nuclei, the fibers will go to the cortex, and from the cortex there is corticospinal tract, which will then initiate the voluntary movement. Start the voluntary movement. Command will be executed according to the plan, according to the sequence which was provided by the neocerebellum or cerebrocerebellum. So cerebrocerebellum is controlling corticospinal tract and initiating the movement and giving the sequence of contractions. Right, so these are the connections of the cerebellum. Finally, let's see the circuit of cerebellum. The cerebellar circuit revolves around two cells. There is a Purkinje cell. This cell was named after the Johannes Evangelista Purkinje, the same person who discovered the Purkinje fiber in the heart. The Purkinje cell, which exerts an inhibitory influence on the deep nuclear cell, and deep nucleus is sending output which goes to various parts. We have already seen that, and deep nuclear output is under inhibitory control of the Purkinje cell. This is the center of part of the circuit, main part of the circuit. Now we have also seen that cerebellum receives double inputs. So, input from the olivocerebellar tract, converged input from multiple sources. They come to the olive first and then a single bundle as olivocerebellar tract. As it enters the cerebellum, it gives out a collateral to excite the deep nuclear cell, and then a deep nucleus will send the excitatory output to the muscles, and then this fiber goes on to climb on the Purkinje cell. This will be called as climbing fiber. It will go on to climb on the Purkinje cell and it will excite the Purkinje cell. What will be the effect of excitation of the Purkinje cell? Purkinje cell will suppress the deep nuclear output. So this is why we have a very fine control on our voluntary movements, very precise movements, very smoothly executed movements, because there is a switch on, switch off, switch on, switch on type of signaling going on all the time via cerebellum. Very fine balance, so that when to start the agonist contraction and suppress the antagonist contraction. When you reach the target, then antagonist will contract, agonist will relax, and it happens in a very smooth and precise manner. Okay, then from the individual multiple sources, the fibers come in. As they come in, they will excite, they give a collateral to excite the deep nuclear cell, and then deep nucleus will send the output. Then this fiber, which is called as mossy fiber, it will first excite another cell in the cerebellum called as granule cell. Granule cell then gives short axons which run to the surface of the cerebellum, superficial layer, surface, and then make a T. These are the T-shaped axons. These are called as parallel fibers. They will then excite the Purkinje cell. So another afferent entered the cerebellum, excited the deep nuclear cell. So there was excitatory output from the cerebellum to the muscles. Then it went on to excite the granule cell excite the Purkinje cell. Excitation of the Purkinje cell means deep nuclear output will be suppressed. Now from all this, it looks as if all the time Purkinje cell is getting excited, and then it exerts the inhibitory influence on the deep nuclear cell. That's not the case. There are three short inhibitory interneurons in the cerebellum: Golgi cell, basket cell, and stellate cell. Golgi cell, basket cell, and stellate cell. All of them are inhibitory interneurons, and they inhibit the Purkinje cell. So granule cell excites the Purkinje cell, fine, and then it will inhibit the deep nuclear output. But granule cell via the short inhibitory interneurons can inhibit the Purkinje cell, and the effect of that would be Purkinje's inhibition on the deep nuclear output will be lifted. Inhibition of Purkinje cell means deep nuclear output will be actually facilitated. So it's a very, very fine balance. We learn the movements and we know how much is each muscle needs to contract to make a very smooth and precise movement. There was a recently discovered cell called as candelabrum cell. Candelabrum cell also makes a candelabrum is candle stand with multiple candle holders. So it makes the axosomatic synapses with the Purkinje cell. That's the circuit of the Purkinje. That's the circuit of the cerebellum. Finally, disorders of the cerebellum. We've already seen a few. There will be ataxia and dysmetria. Ataxia, loss of coordination, because that was the job of cerebellum. Dysmetria and decomposition of the movement completely. Past pointing, damping function has been lost, so past pointing. Adiadochokinesia, failure to perform alternate rapid movements. Loss of muscle tone, because cerebellum was controlling the tone. Apart from this, tremor. Cerebellar tremor is called as intention tremor. At rest, there is no tremor, but when you intend to make a movement, then there will be tremulousness, because now, due to the lesion of the cerebellum, it's not able to control the agonist and antagonist in a very, very precise manner. So you are moving to the target, but then no control on the muscles, agonist and antagonist. So coming back, going forth, coming back, it will produce an intention tremor during the movement. Compare this with basal ganglia tremor, which will be tremor at rest. Romberg sign is positive in the cerebellar lesions. So a person is asked to perform finger nose test or finger to finger test, or lower limb coordination is tested by asking the patient to stand with feet close to each other. That's a Romberg's test. But first with eyes open, then with eyes closed. That's the essence of this test, to test the ataxia. Now, ataxia is loss of coordination, is of two types. Basically, it is because of two reasons. The sensory ataxia and the cerebellar or motor ataxia. You see, if there is a spinal cord lesion, it will result in a sensory ataxia. The signals from muscle are not ascending into the cerebellum. No sensory signals reaching the cerebellum. That then will result in ataxia. Now, what is the significance of this? Let's say, suppose there is sensory ataxia, a spinal cord lesion or such lesion which is not allowing the proprioceptive impulses to reach the cerebellum. Ascending tracts are not allowed to send the signals, unable to send the signals. When the eyes are open, patient will be able to perform the movement, but when the eyes are closed, patient will falter. That's the sign of sensory ataxia, because when the eyes are open, imagine that the patient is not receiving any information from his joints via the sensory pathways, but his eyes are open, so he can see his joints and correct his movements. So he is able to perform that movement. But as the eyes are closed, then now there is no visual input and already there is no information from the joints and the muscles regarding the proprioceptive impulses, then the patient will falter. So eyes open, patient performs the movement. Eyes closed, patient cannot perform the movement. This is the sign of sensory ataxia, loss of proprioceptive impulses going up into the cerebellum. And if there is a cerebellar ataxia, cerebellum itself lesioned, then whether eyes are open or eyes are closed, patient will not be able to perform the movement. So eyes open or closed, both times patients falter. That's a cerebellar or motor ataxia. So that's a cerebellum in summary. So after cerebellum, let us see another important component in the motor system, and that's basal ganglia. Very often I ask the question, what would you call basal ganglia is or basal ganglia are? Well, grammatically the students feel ganglion, ganglia. So it's a plural and therefore it should be basal ganglia are. But that reminds me of a parallel in the history. Until World War I, it's United States were And after the World War I, it is said United States, they started saying United States is. So it's a one unit, although called in plural. So basal ganglia is an acceptable term. These are subcortical masses of gray matter. What MCQ can come or has come already is that which of the following in the basal ganglia, which of the following neurons do not use GABA as the neurotransmitter? And the options are striatopallidal neuron, pallidothalamic neuron, pallidosubthalamic neuron, or subthalamicopallidal neuron. Answer was D actually, subthalamic nucleus to pallidum. Why and how? We will see this when we understand the circuits in the basal ganglia. So let's discuss. There are 5 masses of gray matter near the base of the brain, collectively called as the basal ganglia. These structures are caudate nucleus, putamen, globus pallidus. Globus pallidus has 2 parts, globus pallidus external and globus pallidus internal globus pallidus. Substantia nigra, this also has got 2 parts, pars compacta and pars reticulata. And subthalamic nucleus, also called as body of Lewis. These 5 structures collectively called as the basal ganglia. Now, functionally speaking, connection point of view, caudate nucleus and putamen is considered one. Caudate nucleus and putamen together are considered as striatum or corpus striatum, and globus pallidus is called as pallidum. So we have corpus striatum and pallidum, the globus pallidus. That's functionally or connection wise. Anatomically, there is one more way of looking at these nuclei. These 3 structures, caudate nucleus, putamen, globus pallidus, are on either side of the internal capsule. So on one side there is caudate nucleus, and on the other side the putamen and globus pallidus together form the lentiform nucleus. So we have caudate nucleus, and on the other side of the internal capsule, putamen and globus pallidus together form the lentiform nucleus. This lentiform nucleus, for instance, is involved in the Wilson's disease, hepatolenticular degeneration, excess deposition of copper in the lentiform nucleus and the liver. So that's the lentiform nucleus and hepatolenticular degeneration. Well, this is what is the composition of the basal ganglia. These 5 structures are involved. We have seen that basal ganglia is exclusively connected with the cortex, means circuits cortex to basal ganglia back to cortex. So what are the generalized features of basal ganglia circuit? All the afferents obviously coming from the cortex. Basal ganglia has exclusive connection with the cortex. So all afferents are coming from the cortex. They end in the striatum. And all efferents, they emerge from the pallidum. That is internal globus pallidus. These are some of the generalized features of the basal ganglia circuit. All efferents that go out from the basal ganglia and go back to the cortex, they arise in the internal globus pallidus. Also, for the sake of remembering, we can say that only the fiber coming from the cortex, is excitatory, and fiber going back to the cortex, reaching back to cortex, is excitatory. All the other fibers are inhibitory. This is for the sake of how you remember the circuit and excitatory and inhibitory pathways. So remember, for now, the fiber coming from the cortex into the basal ganglia would be excitatory fiber, and fiber that is finally reaching back to the cortex is excitatory fiber. The others are inhibitory. So let's now see the circuits of the basal ganglia and how they play a role in movement, voluntary movement. We have two circuits, the direct circuit and the indirect circuit. So let's see the direct circuit first. Cortex, when it is thinking of a voluntary movement, it will start exciting the basal ganglia. See how. Cortex will send signals to the striatum. This is a corticostriate projection, and we have said that this is excitatory fiber. Striatum will now start, striatum sends fiber to the pallidum. So this is the pallidum. Striatum to pallidum. Internal globus pallidus. From the internal globus pallidus, we have already discussed that the fiber that goes out is from the internal globus pallidus. So this fiber goes out to the thalamus. We also know that there are three thalamic nuclei involved in the motor function, are ventro-anterior, ventrolateral and centromedian nuclei. And via these nuclei, the signals will go back to the cortex, completing the circuit. That's the direct circuit. So we have already said that the fiber that goes back to the cortex is excitatory, and the fiber coming in was excitatory. All others are inhibitory. So striatum to pallidum, inhibitory, and pallidum to thalamus is also inhibitory. Now, one very crucial aspect that should be remembered is that pallidothalamic projections, they have background tonic inhibitory activity. Background tonic activity. Repeat this again, try to understand. Pallidal neurons of the GPI, they are continuously inhibiting the thalamic neurons as a tonic activity. Tonic activity means activity at rest. This is the signaling at rest. Even when the person is not making any voluntary movement, the body is at rest, the muscles are resting. Even then, the pallidal neurons are continuously sending signals to thalamic neurons and inhibiting the thalamic neurons. So this activity at rest, this tonic signaling at rest is the basis for tremor at rest in Parkinsonism, in the lesions of the basal ganglia. That at rest there is some activity which was going on under normal circumstances, and its signal gets lifted in Parkinsonism and resulting in the tremor at rest, as we will see later. So that's the Parkinson's, that's the, I beg your pardon, circuit, direct circuit, and these are the excitatory and inhibitory fibers. Let us try to understand the function of the direct circuit. When cortex starts thinking of a voluntary movement, it starts exciting the striatal neurons. Corticostriate projections will be activated. What will be the effect of that? Striatum will now start inhibiting the pallidal neurons. But what will be the effect of that? There was already background tonic inhibitory activity which was going on. Pallidothalamic projections are inhibitory and they are continuously inhibiting the thalamic neurons. So that tonic inhibitory activity will now be inhibited when cortex starts thinking of a voluntary movement. Cortex excites the striatal neurons. Striatal neurons now start inhibiting the pallidal neurons, and that results in inhibition of this background tonic inhibitory activity on the thalamic neurons. So this is called as disinhibition, inhibition of the already going on inhibition. Therefore, because that background tonic activity of the pallidothalamic neurons is inhibited now, thalamus will give a go ahead to the cortex and make the movement. So what is the function of the direct circuit? Direct circuit has a function. It facilitates the selected movement, facilitates the movement. It has to select the correct movement and then facilitates the movement. That's the job of the direct circuit. Next, there is indirect circuit. This will include just one extra additional structure. The indirect circuit will have a subthalamic nucleus. Below the thalamus, there would be this subthalamic nucleus. So let's see the indirect circuit now. Cortex to striatum, striatum to pallidum, but this time first the external globus pallidus. External globus pallidus to the subthalamic nucleus. We have already seen that striatum to pallidum are inhibitory neurons. Just like pallidothalamic projection is inhibitory and it has got a background tonic inhibitory activity, similarly pallido-subthalamic projection is also inhibitory. Pallido-subthalamic projection is also inhibitory. It has a background tonic inhibitory influence on the subthalamic nucleus neurons. And then subthalamic nucleus back to GPI. And then internal globus pallidus sends the fiber out of the basal ganglia to the thalamus. Rest of the circuit is same. So just add one more feature in this. Subthalamic nucleus to the GPI. This is an excitatory fiber. This is called as a reciprocal connection, that globus pallidus to subthalamic nucleus, inhibitory fiber, subthalamic nucleus to globus pallidus, excitatory fiber, reciprocal connection. Now, what is the function? Let us solve the circuit first. When cortex starts thinking of a voluntary movement, it excites the striatal neurons. Corticostriate projections are excitatory. What is the effect of that? Striatum will now start inhibiting the pallidal neurons. And what will be the effect of that? The pallidosubthalamic inhibitory projection will be inhibited now by this. When striatum starts inhibiting the GPE, the effect is the GPE's inhibitory influence on the subthalamic nucleus will be lifted. What will be the effect of that? Subthalamic nucleus will now start facilitating the GPI. It's an excitatory connection. And what will be the effect of that? The GPI's inhibitory projection will be now facilitated. That background tonic inhibitory activity will be facilitated. So thalamic neurons will be inhibited and they will not give a go ahead to the cortex to make the movement. So what is the function of the indirect circuit? Function of the indirect circuit is inhibition of the movement, suppression of the movement, or inhibition of the movement. It is an inhibitory circuit all in all. So one movement has been selected, which is the most appropriate desirable movement, and others related movements will be suppressed or inhibited. That's how basal ganglia circuits will work. What is the role of substantia nigra in this? Let's try to understand the role of substantia nigra. Substantia nigra is not involved directly in these circuits. Substantia nigra not involved in the basal ganglia circuits directly. So what is its function? Its function is modulate the activity of striatal neurons involved in the direct and indirect circuits. Substantia nigra, its function is modulate the activity of striatal neurons involved in the direct and indirect circuit. So these will be called as nigrostriatal projections. Nigrostriatal projections. Nigrostriatal projections are going to modulate the activity of striatal neurons involved in the direct and indirect circuit. These are dopaminergic projections, as you must have already read that these are dopaminergic projections. D1 dopaminergic projection and D2 dopaminergic projection. There are 5 dopamine receptors, D1, D2, D3, D4, D5, out of which we are concerned with 2. D2 mediates the inhibitory effects of dopamine and D1 mediates the excitatory effects of dopamine. So D1 dopaminergic projection, nigrostriatal projection, will be excitatory. D2 nigrostriatal projection is inhibitory. D2 receptors mediate the inhibitory effects of dopamine. So what are the functions of these nigrostriatal projections? D1 dopaminergic projection facilitates the direct circuit. Facilitates the direct circuit. It ends on the direct circuit and it facilitates the direct circuit. But what will be the effect of that? Direct circuit was facilitating the movement, so that will be facilitated. Movement will be facilitated. Then D2 dopaminergic projection. D2 dopaminergic projection, inhibitory projection, what is its function? Inhibition of the indirect circuit. Inhibition of the indirect circuit. What will be the effect of that? You see, indirect circuit was inhibiting the movement, suppression of the movement. That will be inhibited, means the movement will be facilitated. So remember, substantia nigra and the nigrostriatal projections are there to facilitate the movement, and therefore in the lesions of basal ganglia, in the Parkinsonism, when there is degeneration of nigrostriatal tract, it results in bradykinesia or hypokinesia, because these projections were meant to facilitate the movement, and that they have degenerated. That means movement will not be facilitated. There will be bradykinesia. Movements will be very, very less pronounced. Okay. These are the direct and indirect circuits and role of substantia nigra. Just one last point is, who will tell the substantia nigra to perform its job. It will be the cortex. As cortex excites the striatal neurons have a reciprocal connection with the substantia nigra, striatonigral projection, and this is the cholinergic projection. The neurotransmitter is acetylcholine. So if you remember, in Parkinsonism, when there is degeneration of these dopaminergic neurons, either you give dopamine, replenish the dopamine, or you give anticholinergic drugs to block this particular fiber. This is going to have unchecked activity, excess activity, because of degeneration of the dopaminergic neurons. This is a reciprocal innervation. So therefore you have to block this acetylcholine. You give anticholinergic drugs as an adjuvant to dopaminergic therapy, or in Parkinsonism the dopamine is given. So that's these are the circuits in the basal ganglia. These are their functions. Let's see some additional aspects. I have already mentioned one part, the functions of these circuits. What is the function of the subthalamic nucleus? The function of the subthalamic nucleus is to control the associated movements of the body. Associated movements of the body are controlled from subthalamic nucleus. So, and the lesion of subthalamic nucleus results in hemibalismus. You see, what are associated movements? Swinging of the arms while walking is an associated movement. While walking, the swinging of the arms is the associated movement, and therefore lesion of the subthalamic nucleus results in hemibalismus. Hemibalismus is ballistic movements of one half of the body. That's hemibalismus. Apart from this, a few more points that may be remembered is that there are two types of diseases related to the basal ganglia. The lesions of the basal ganglia result in two types of diseases. One is Huntington's disease and the other is Parkinson's disease. Parkinsonism is a hypokinetic disorder. Movements are lost. Huntington's disease is the hyperkinetic disorder. Excess movements are seen. Hyperkinetic disorder. Well, Huntington's disease is because of the Huntington gene. What happens is it's a trinucleotide repeat disease, trinucleotide expansion disease. There are normally about 42 repeats of the trinucleotide CAG, but it's expanded and there are 78 repeats or more of the CAG. That's a trinucleotide expansion disease. It results in what? It results in, or the basic defect in the Huntington disease is intrastriatal degeneration of GABAergic and cholinergic neurons. GABAergic neuron going from striatum to the pallidum, and cholinergic neuron going from striatum to the substantia nigra. Both these neurons are degenerated in the Huntington's disease. So these two are the main disorders associated with the lesions of basal ganglia. Lesion of the caudate nucleus or corpus striatum will result in coriform movements. lesion of the pallidum or pallidothalamic projections, they have the background tonic activity which is under inhibitory control, that will result in the tremors. So these are some of the features associated with the basal ganglia. Let us now discuss the lower motor neuron. Before we start the discussion, let me ask you two MCQs at the startup. In a muscle spindle, what is the ratio of nuclear bag to nuclear chain intrafusal fibers in a muscle spindle? 1:1, 1:3, 3:1, or 1:20? The answer is 1:3. Okay, one more. In the Golgi tendon organ, or rather, what is the ratio of Golgi tendon organ to the tendon fibers? And the options are 1:1, 1:3, 3:1, 1:20. Well, the answer is 1:20. Let's try to understand all these. Lower motor neuron. Over here we are talking about the motor neuron that starts from the spinal cord and goes to the muscle. This lower motor neuron, also called as anterior motor neuron, because it starts from the anterior horn of the spinal cord. This motor neuron is of two types. The alpha motor neuron and the gamma motor neuron. The alpha motor neuron and the gamma motor neuron. So anterior motor neuron or the lower motor neuron, or it's of two types, the alpha motor neuron and the gamma motor neuron. So there are two types of muscle fibers in the muscle. Two types of fibers. One, there are large extrafusal fibers on the outside. These are large extrafusals. And there are small intrafusal fibers near the belly of the muscle. Small intrafusal fibers. These small intrafusal fibers are connected to the extrafusal fibers with the surrounding glycocalyx. They are connected with the large extrafusal fibers. Then you can see here that alpha motor neuron innervates the extrafusal fibers. Gamma motor neuron innervates the intrafusal fibers. Muscle contraction is the contraction of extrafusal fibers. So muscle contraction is brought about by the alpha motor neuron, which causes the extrafusal fibers to contract. Then what is the role of intrafusal muscle fibers? Intrafusal fibers. They are short, they are small, they cannot cause the muscle to contract. They form what is called as proprioceptor in the muscle. So let us discuss the proprioceptors in the muscle first. There are two types of proprioceptors in the muscle. One in the belly of the muscle and formed by the intrafusal fibers. This is called as muscle spindle. So just note this point, that intrafusal fibers, they will form the muscle spindle at near the belly, central part of the muscle. The other proprioceptor is situated in the tendon of the muscle, and it is made up of tendon fibers. It's called as Golgi tendon organ. So second proprioceptor is in the tendon of the muscle, is made up of tendon fibers. It is called as Golgi tendon organ. Golgi tendon organ. These are the two proprioceptors in the muscle. Now, if you remember the discussion on muscle contraction, you will realize that muscle contraction means two things. When the muscle contracts, two things are happening. A, muscle length is changing, there is shortening of the muscle, and B, tension is developed in the muscle. So muscle contraction means these two things. Tension is developed in the muscle and muscle shortening happens, means length changes. So to detect these two dimensions of contraction, we have two proprioceptors in the muscle. Muscle spindle detects the length of the muscle. One dimension of the contraction is shortening, change of length. So length of the muscle and rate of change of length of the muscle. Length of the muscle when muscle is stationary, and rate of change of length of the muscle. When the muscle is making a continuous contraction, there is a continuous voluntary movement, the length is changing continuously. How fast it is changing, that's called as rate of change of length of the muscle. That's also detected by the muscle spindle. Similarly, Golgi tendon organ detects what? It detects tension in the muscle. The other dimension of contraction is tension development. So it detects the tension in the muscle and rate of change of tension of the muscle. So these are the two proprioceptors in the muscle. Let us see these proprioceptors one by one. First, the muscle spindle, which is made up of intrafusal fibers. About 10 to 12 intrafusal fibers make one muscle spindle. Out of these, 2 to 3 fibers are nuclear bag intrafusal fibers, and about 8 to 9 are nuclear chain intrafusal fibers. So, in a muscle spindle, the ratio of nuclear bag to nuclear chain is 1:3. If we look at the structure in detail, there was an MCQ like this: which of the following is not involved in the dynamic stretch reflex, like knee jerk? And the options were flower spray endings, primary or 1A afferents, alpha motor neuron, and extrafusal fibers. The answer was flower spray ending. Let's see how. This is a nuclear bag intrafusal fiber, and then there is nuclear chain intrafusal fiber. These are the two types of intrafusal fibers, and they are attached by a surrounding glycocalyx to the extrafusal fibers on the outside. Now, so far as the innervation is concerned, from the central portions of both the nuclear bag and nuclear chain fibers, from their central portions, there are annulospiral endings. Annulospiral endings. Note that these endings are there for both the nuclear bag and nuclear chain. These annulospiral endings then join to form the primary or 1A afferent. Primary or 1A afferent. We've already seen this in the discussion on nerve, that the nerve fiber types like A alpha, A beta, A gamma, A delta, B and C, among these fibers there are sensory fibers that are taken out to have a numerical classification of those fibers. So 1A, 1B, 2A, 2B, 3 and 4, such types of fibers are there. Sensory fibers classified numerically as 1A, 1B, 2A, 2B, 3 and 4. So that's a primary or 1A afferent. It enters the spinal cord and ends on the alpha motor neuron. Alpha motor neuron will go back and innervate the extrafusal fiber. This is the circuit for dynamic stretch reflex. These are the components of dynamic stretch reflex. The knee jerk is an example of dynamic stretch reflex. When you tap over the tendon, the muscle is stretched suddenly. Therefore, the intrafusal fibers are stretched suddenly. The receptor portions are their central portions, equatorial portions are the receptor portions. They are stimulated. They will be sending signals via the primary or 1A afferents, which will enter the spinal cord and end on the alpha motor neuron. Alpha motor neuron goes back and causes a brief contraction of the extrafusal fiber, which is seen as the jerk. That's the tendon jerk, knee jerk, and it's a dynamic stretch reflex. Let me just add one more thing in this. What is the role of gamma motor neuron? The role of gamma motor neuron is to maintain the excitability of the muscle spindle. To maintain the excitability of the muscle spindle by pulling the ends of the intrafusal fibers. So gamma motor neuron, by pulling the ends of the intrafusal fibers, it maintains the excitability of the receptor portions. That's the job of gamma motor neuron. And therefore, let me mention two things in the context of gamma motor neuron. One is Gendrasik maneuver. Gendrasik maneuver. When you don't get the knee jerk properly, we have already said that receptor for the knee jerk is the muscle spindle, these intrafusal fibers. When you don't get the knee jerk, sometimes you ask the patient for hooking of the fingers or clenching of the teeth. This is called as Gendrasik's maneuver. What does it achieve? Gendrasik's maneuver increases the gamma motor neuron discharge to the muscle spindle. You see, when hooking of the fingers like this, afferents from the skin, they will go to the spinal cord and they will cause excitation of the gamma motor neuron. So gamma motor neuron will pull the ends of the intrafusal fibers and will maintain the receptor excitability at the central portions. So after that, when you strike over the tendon, you are likely to get the dynamic stretch reflex, the knee jerk. That's the Gendrasik's maneuver. Increases the gamma motor neuron discharge so that we get the knee jerk. And the second is alpha gamma coactivation or alpha gamma linkage. You see, muscle contraction is the job of alpha motor neuron. Alpha motor neuron innervates the extrafusal fibers, and when it causes extrafusals to contract, the muscle is contracting, movement will happen. Fine. But then if the muscle is contracting continuously, what generally happens or likely to happen is that the intrafusal fibers get compressed when the muscle is in a continuous state of contraction and when we are making a continuous voluntary movement. Muscle is contracting continuously, so intrafusal fibers get compressed and their central portions, which are the receptor portions, they will be relaxed. This is called as unloading of the muscle spindle. This is called as unloading of the muscle spindle. Muscle spindle is unloaded. It's relaxed. So, even though you are getting the muscle contraction, but you will not get any signals from the muscle spindle regarding the change of muscle length. So no signals will arise from the muscle spindle and go back to the cerebellum. So cerebellum will be in the complete dark regarding what is happening at the muscle level. Contraction will be achieved though, but no feedback signals because muscle spindle is unloaded. Therefore, what happens is alpha gamma co-activation, simultaneous activation, that the cerebellum tells alpha motor neuron to cause muscle to contract, at the same time excites the gamma motor neuron, go and excite the muscle spindle, go and maintain the excitability of the muscle spindle. That's the job of gamma motor neuron. So it will maintain the excitability of the muscle spindle so that even as the muscle is contracting, muscle spindle will not be unloaded. It will keep on sending proprioceptive feedback signals to the cerebellum. So that's the gamma motor neuron and its role in the overall muscle spindle excitability. Let's just see one more innervation in the muscle spindle and then we discuss the Golgi tendon organ. From the ends of the nuclear chain intrafusal fibers, only from the nuclear chain, not nuclear bag, mind you, there are endings which are called as flower spray endings. Flower spray endings. They give rise to another afferent which is called as secondary or type 2 afferent. This detects what? This detects the static stretch of the muscle. The other one was dynamic stretch, that is when the muscle was suddenly stretched. Static stretch when the muscle is in a contracted state and there is a static stretch on it. That is detected best by these flower spray endings because they are at the poles of the nuclear chain fiber. You see, this area is quite close to the extrafusal fiber. It has got the same viscoelastic property as that of the extrafusal fiber, and therefore a steady stretch on the extrafusal fiber can be detected best in this region, and therefore this static stretch will be conveyed to the cortex, and this static stretch will be also involved in maintenance of the muscle tone, a contracted state. So that's a receptor in the muscle called as muscle spindle and the dynamic stretch reflex. Let us discuss the other proprioceptor in the muscle, and that is Golgi tendon organ. Golgi tendon organ. Situated in the tendon of the muscle with a ratio of 1:20 with the tendon organs, with the tendon fibers. About 20 fibers will make one Golgi tendon organ. So this is the Golgi tendon organ situated in the tendon of the muscle. Arising from the Golgi tendon organ is the 1B type of afferent. 1B type of afferent. This afferent then enters the spinal cord and it ends on an inhibitory interneuron, which then ends on the alpha motor neuron. And alpha motor neuron goes back and innervates the extrafusal fiber. So, note this point. Reflex initiated by the Golgi tendon organ is a disynaptic reflex. Reflex initiated by the muscle spindle was a monosynaptic reflex. There were only 2 neurons and 1 synapse in the case of muscle spindle initiated reflex. Golgi tendon initiated is a disynaptic reflex. As you can see here, there are 2 synapses involved. Second point, reflex initiated by the muscle spindle was excitatory to the alpha motor neuron and to the muscle. Reflex initiated by the Golgi tendon organ will be always inhibitory to the alpha motor neuron. This is an inhibitory interneuron which ends on the alpha motor neuron. So, Golgi tendon organ initiates the reflex which will inhibit the alpha motor neuron. and that's the basis for the clasp knife reflex, that is spasticity seen in the pyramidal lesions. In the pyramidal lesions, which is an upper motor neuron type of lesion, we have already said that in the upper motor neuron lesions, that inhibitory influence on the lower motor neuron is gone, and therefore lower motor neuron fires excessively. That's now seen as increased muscle tone. So imagine that the muscle tone has been excessive, increased muscle tone in the pyramidal tract lesion. And then if you try to clinically just stretch the muscle further, what's likely to happen is, already the muscle is hypertonic and you stretch it further, the muscle is likely to be torn or tendon is likely to be avulsed. There is a possibility of damage to the muscle. So Golgi tendon organ, which is actually detecting the tension in the muscle, initiates the reflex even as you stretch the muscle slightly. It initiates the reflex and it inhibits the alpha motor neuron. So what happens is, as you stretch the joint passively, initially you get a lot of resistance because the muscle is hypertonic, but beyond a certain point, that GTO initiated reflex will relax the muscle completely. So beyond a certain resistance, the resistance will collapse and muscle will completely relax. This is called as lengthening reaction. Lengthening reaction. Muscle lengthens and relaxes completely because of the reflex initiated by the Golgi tendon organ. Normally when the muscle is stretched, it responds by a brief contraction, shortening happens. But here when the muscle is stretched, it responds by lengthening reaction. So it's somewhat similar to the opening of a pocket knife. Initially there is resistance while opening the pocket knife, but beyond a certain point it completely gives way and opens quickly. So somewhat similar happens when you try to stretch the joint passively, and this is what is the basis for spasticity seen in the pyramidal lesions. So hypertonias basically of two types, spasticity and rigidity. Spasticity is seen in the pyramidal lesions, pyramidal tract lesion. Rigidity is seen in the extrapyramidal lesions. Example, lead pipe rigidity. Lead pipe rigidity. It's like this. When you try to bend a lead pipe, throughout the bending you will feel resistance. And when you leave the lead pipe after certain bending, it remains in that position, in a bent position. Similar thing happens in the extrapyramidal lesions, the rigidity. See, both are hypertonias, but they have certain important differences. Rigidity, for example, lead pipe rigidity, is seen in extrapyramidal lesions. Spasticity is unidirectional. Rigidity is bidirectional. That's an important aspect. Spasticity just involves one group of muscles around the joint, the agonists, but not the antagonists. Whereas rigidity will involve both agonist and antagonist. All muscles around the joint will be involved in the rigidity, and therefore, look, in the case of spasticity, beyond a certain point, Golgi tendon organ could initiate a reflex and muscle could completely relax because it was unidirectional. Rigidity involving all the muscles around the joint, they all are hypertonic. So the muscle will not be able to relax even though Golgi tendon organ is initiating the lengthening reaction and trying to relax the muscle. However, this is lead pipe rigidity which we are saying, but in this sometimes what happens is, Alternately, in the agonist and antagonist, their Golgi tendon organs fire the lengthening reaction. Alternately in the agonist and antagonist. So the lead pipe rigidity, which is going to have throughout the movement resistance, now there are series of catches in that. Rigidity comes and goes, comes and goes, comes and goes like that, and therefore it has got extended to another type which is called as cog wheel rigidity. So lead pipe extends into cog wheel if the Golgi tendon organs of the agonists and antagonists, they are firing alternately and trying to relax the agonist and antagonist alternately. Spasticity is velocity dependent. Rigidity is not velocity dependent. Velocity of stretch will also be a factor in eliciting the spasticity, whereas rigidity will be rigidity no matter what. So these are some of the differences between spasticity and rigidity, and that's the lower motor neuron. Upper motor neuron lesions result in these spasticity and rigidities, whereas if there is a lower motor neuron lesion in the alpha or gamma motor neuron, it will result in the complete hypotonia, because signals will not be reaching the muscle. So that's the lower motor neuron. Let's take one more aspect of the motor system, and that is postural reflexes. Postural reflexes. Let's see a quick synopsis of the postural reflexes. You see, there was an MCQ like this: which of the following is the most basic postural reflex? A stretch reflex, positive supporting reaction, negative supporting reaction, or Philipson's reflex? The answer is stretch reflex. So postural reflexes are the reflex redistribution of tone, by which reflex redistribution of tone in the various groups of muscles to maintain a certain posture. That's a postural reflex. That's the maintenance of posture. How do we maintain our posture, whatever desired posture, upright posture? Is that there is reflex redistribution of tone in the groups of muscles, and that's how we maintain our posture, whatever is desired. Now, most basic postural reflex is a stretch reflex. We have already discussed the stretch reflex. The knee jerk is a stretch reflex. For instance, the muscle spindle is the receptor for it, and primary or 1A afferent arising from it enters the spinal cord and ends on the alpha motor neuron. Alpha motor neuron goes back and innervates the extraphyseal fiber. This is the circuitry for stretch reflex. So imagine if the knee is suddenly stretched by hammering over the tendon, then entire muscle is stretched, intraphyseal fibers are stimulated, and they cause a brief contraction of the muscle. This will result in the knee jerk and extension at the knee joint. So imagine its application in day-to-day life. If you happen to slip over a peel of banana, what will happen? Sudden stretch of the muscle, and there would be a brief contraction of the muscle. The limb will become a rigid pillar to support the body weight and maintain the upright posture. That's the applicability of the knee jerk, and therefore most basic postural reflex is the stretch reflex. The muscle gets stretched and it responds by a brief contraction. Now, to study the postural reflexes, we prepare some experimental animal preparations. For example, we take transection at the upper border of spinal cord, uppermost level of the spinal cord. this will be called as the spinal animal. So, only those postural reflexes whose center is in the spinal cord, only those postural reflexes will be visible, will be seen in this spinal animal when transection is made at the uppermost part of the spinal cord, uppermost level. Then we take another experimental preparation called as decerebrate animal, decerebrate rigidity or decerebrate animal preparation. Now in this, transection is made in the mid-collicular level, between superior and inferior colliculi. A transection is made. What is retained in this animal, decerebrate animal, is spinal cord and then vestibular nuclei. So what I'm trying to say is, when you learn the postural reflexes, you make the experimental animal preparations, they have two advantages, two benefits are offered in these animals. One is that we are taking a transection and removing the parts above that transection. Means what? We are actually removing the cortical inhibitory influence on the lower neurons. We have already seen that cortex and the descending neurons exert an predominantly inhibitory influence on the lower neurons. So when we take a transection like this at the upper border of spinal cord or mid-collicular transection, and we remove the parts above it, that means we are removing the inhibitory influence of the cortex on the lower neuron, so that the reflex will become prominent and we will be able to study the reflex, which is the center and all the aspects of the postural reflex. So that is one benefit of making such experimental preparations by making transections. Second important benefit is we get to know about the center of the reflex. What is the center of the reflex? For example, see, if we see certain reflexes in the spinal animal, and we know that the center will be in the spinal cord, but we don't see certain postural reflex in the spinal animals, but we see those postural reflexes in the decerebrate animal. What is the inference that you draw? It would mean that the center is vestibular nuclei. So when you made a spinal animal, you took transection at the upper border of spinal cord and removed all the things above, you could not see that reflex. But when you made a decerebrate animal, you have retained spinal cord and vestibular nuclei. Now the reflex can be seen. Now that postural reflex is seen, that means center is in the vestibular nuclei. Next, if we take transection even higher up, it's called as midbrain animal or thalamic preparation. So what is now retained? I mean, we have taken a transection above. We are retaining spinal cord, vestibular nuclei, and we are retaining the red nucleus also in the midbrain animal. So now it's clear why we make these preparations. The postural reflex, which was not seen in the decerebrate animal, but it is seen in the midbrain animal, it's present in the midbrain animal. That means the center is the red nucleus, which we had removed in the decerebrate animal, but it's there in the midbrain animal. So that's how we get to know about the center of a postural reflex. Finally, if we just take the highest lesion, just remove a certain layer of the cortex, that's it. This is called as decorticate animal. Decorticate animal. Just remove a layer of cortex. That's a decorticate animal. So just removes the higher conscious function. Now, what is the difference between decerebrate rigidity and decorticate rigidity? Decerebrate rigidity, as in, is more like lower animals. Decerebrate cat, extensors of all the limbs will contract. All extensors will go into spasm, into rigidity. That's a decerebrate rigidity. In the case of decorticate rigidity, such rigidity is more, it resembles more humans. It's more like humans, because in decorticate rigidity, extensors of the lower limb and flexors of the upper limb go into spasm. So imagine decerebrate rigidity, all extensors go into spasm, rigidity they show, because in lower animals who walk on all four limbs, all extensors of all four limbs are the postural muscles, anti-gravity muscles rather. But in humans, extensors of the lower limbs and flexors of the upper limb are the anti-gravity muscles, and therefore they go into rigidity in decorticate rigidity. So these are the experimental animals. First of all, you need to understand what all things have been retained and why these sections have been made one after the other or one above the other to study the postural reflexes. So let's see the postural reflexes. Let us discuss the postural reflex. Most basic reflex is the stretch reflex. We've already said that. There are local postural reflexes, local static reflexes. Just one or two spinal cord segments and one side is involved. That's a local static reflex. Just one or two spinal cord segments, and that too one side of the spinal cord involved. So positive supporting reaction. And remember, these are static reflexes, means animal will be stationary and will be somehow maintaining the posture and will be stationary. So that's a static reflex. A positive supporting reaction, also called as magnet reaction. Stimulate the sole of the foot. Go on stimulating the sole of the foot and you see extension of the limb. Limb becomes a rigid pillar to support the body weight. This is called as positive supporting reaction. Limb supports the body weight, becomes a rigid pillar. Why it's called magnet reaction? Because the direction in which you go on stimulating, the contraction goes on getting stronger in that direction. So it's called as magnet reaction. And this is seen in the spinal animal. Center is spinal cord. Negative supporting reaction. Sometimes release from the positive supporting reaction is also a postural reflex. This is also seen in the spinal animal. Center is in the spinal cord. Now, segmental static reflexes. Segmental static reflexes means entire segment and both sides are involved. So that's a crossed extensor reflex. Crossed extensor reflex, sometimes called as Philipson's reflex. When one limb is flexed, the opposite limb begins to extend. So both sides of the spinal cord are involved. One limb flexed, other limb extends to support the body weight. That's a crossed extensor reflex, and entire segment, both sides are involved in this. Now, next, general static reactions. general static reactions. These are not seen in the spinal animals. They will involve the entire body or major part of the body. Unlike just the above reflexes, they were involving just one or two limbs. But here most of the body parts are involved, entire body is involved. Animal will be maintaining the upright posture in a very insecure way. But animal cannot actively assume the upright posture. So, what are those reflexes? Tonic neck reflexes. Tonic neck reflexes and tonic labyrinthine reflexes. What are tonic neck reflexes? Imagine that you are looking below a table. That is flexion at the neck. How will you maintain the posture? Extension of the hind limb and flexion of the forelimb. Imagine you are looking above a shelf. How will you maintain the posture? Flexion at the hind limb, extension at the forelimb, upper limb. So, these are the tonic neck reflexes. Or turning the chin on one side, and if you see extension on that side and flexion on the opposite side, these are the tonic neck reflexes. Means impulses start from the neck proprioceptors and they maintain the posture. This is not seen in the spinal animal, but this is seen in the decerebrate animal. That means vestibular nuclei are the centers for these reflexes. Even tonic labyrinthine reflexes. Imagine the animal is placed on the floor or on the table and the head drops. As the head drops, there is immediately extension of all four limbs. That's tonic labyrinthine reflex, because as the head dropped, head fell, there was a stimulation of the labyrinth and it resulted in extension of all four limbs. So this is also seen in the decerebrate animal, and vestibular nuclei are the centers. So they are showing that animal can insecurely maintain the upright posture. But in these, the animal cannot actively take up the upright posture. But if it is given the upright posture, then it will insecurely maintain it. The next reactions are writing reactions. Writing reactions are the chain of events, series of events which occur one after the other. That the animal rights the head up, corrects the head, and the body follows the suit, and then finally animal actively assumes the upright posture by itself. So if a cat is thrown from the 10th floor, it lands on its all fours. Or if you have seen horse getting up from the horizontal position, with a series of events. First the head comes up, because of that the neck is twisted, then the signals are sent to the red nucleus and the further parts of the body get up one after the other. This is a series of events. So writing reactions, but remember these are not seen in the decerebrate animals and they are seen in the midbrain animal. That means the center is red nucleus. And the difference between the previous reactions and these reactions is that in those reactions animal could not actively take up upright posture. In this, the animal assumes the upright posture actively. It's a series of events, one after the other. First the head is coming up right way up, then upper part of the body, then the lower part of the body. Like that, in a series of events, the upright posture is assumed. You just have to imagine the horse getting up from the horizontal position from the ground, how it happens one after the other, and then that's an example. And finally, There are certain reactions which need an intact cortex. They are not seen in any of the experimental preparations. They need intact cortex. So what are those? Optical writing reaction. Optical writing reaction. It needs a visual cortex. What is the reaction? When you are falling, posture is getting disturbed. You can see that the building is tilted, trees are tilted, so your posture has been disturbed. And then you maintain the upright posture by contraction of anti-gravity muscles. But it needs an intact cortex because image has to be formed and it has to be perceived that the building tilted, trees are tilted. Hopping reaction and placing reaction. Hopping reaction and placing reaction. If you are displaced laterally, how do you prevent the fall? How do you maintain the upright posture? You hop. You take 2-3 steps and hop. Or you place the foot at a distance firmly on the ground to prevent the fall. So even this needs an intact cortex. These are the postural reflexes with their centers. So that's the discussion on motor system.